one, you know the other. With me? All right, we're going to start with our first set of sisters. Beta blockers and calcium channel blockers. Beta blockers? Same. They're almost exactly the same. Okay. So, what's the one thing I told you to always pick on a select all that apply for anything that affects blood pressure? Change position slowly. Okay. What blood pressure do we have to hold antihypertensive? At what blood pressure do we hold? Less than 90/60. What about heart rate?
60.
Less than 60. Y'all have already learned a lot, so we can move on. So as you can see on antihypertensives, up at the top, it says hold if heart rate less than 60 and blood pressure less than 90/60. All right. So the first drug class is beta blockers. These end in LOL, and you can take that to the bank. Cross the board. If it ends in LOL, it is a beta blocker. Okay, so we've got propranolol and metoprolol. Okay. The beta blockers give you a parasympathetic response. They're downers, right? So what's that going to do to your heart rate? And your blood pressure. Right. Yes, but these you're actually giving a drug, so it may decrease it to lower than normal. Okay. So these beta blockers, they block beta 1, which is in the heart, and beta 2, which is in the lungs, because you've got 1 heart and 2 lungs. Okay. So it also tells the kidneys to decrease renin. What's renin? The RAS system. What's the end result of the RAS system? Right. So if I'm decreasing the RAS system, then it's going to excrete it. Okay. So that's how it's going to help you to decrease your blood pressure. Okay. So beta blockers and calcium channel blockers, look in the MOA. They both do the exact same 4 things. I put them in a different order just because one does something better than the other. But they both do 4 things. They decrease heart rate. They decrease blood pressure. They decrease contractility, and they decrease electrical activity. Boy, that tells the heart to just sit down and shut up, doesn't it? Okay. Yeah. So we use beta blockers to treat angina, right? Because it's going to lower the blood pressure, lower the heart, chill it out a little bit. Hypertension, dysrhythmias. Why would we use them for glaucoma? Intraocular pressure, so it decreases pressure, right? We can use it in an MI when their heart's freaking out and going crazy. We can slow that down, okay? Now, CHF, I don't like to use beta blockers for because it decreases contractility. But if you remember, y'all may not remember this, I don't know, you may have never heard it. In congestive heart failure at the very beginning, because their heart can't pump hard because it has no contractility, it has to pump fast. So that's why they use beta blockers. But you've got to be careful with beta blockers and heart failure because you don't want it to decrease the contractility too much because you already have bad contractility, right? We will also use beta blockers for hyperthyroidism. How would that work? Hyperthyroidism is everything is, so beta blockers would parasympathetic and lower it. Okay. They can use it for migraines because migraines are when you have too much blood in the brain. So it will decrease the pressure. We can also use it for anxiety because beta blockers are giving you a parasympathetic response. Does that make sense? Okay. So beta blockers just
calm those down.
Yes. All right. So we would expect to see bradycardia and hypotension because that's 2 of the functions of what beta blockers do. Okay. Adverse effects. It can cause CHF because it decreases contractility. Very good. Very good. It can cause AV heart block where they're
not talk.
It can decrease your cardiac output. Oh no, that's bad. Okay. What would you assess for if you thought they were getting decreased cardiac output? Signs of poor perfusion. Now it can also cause bronchoconstriction. Why would it cause bronchoconstriction? What happens in the parasympathetic response? You bronchoconstrict. Okay. So who do we not want to give beta blockers to? Asthma. But I put NS. NS means non-selective. So I want you to go back to where it says drugs in class. You see where it says propranolol on the far left. NS. Non-selective. Metoprolol is S, which is selective. So non-selective means it blocks beta 1 and beta 2. And where was beta 2? The lungs. So those can cause the bronchoconstriction. We don't want that. So if you have a patient that has lung issues, you want to give them a selective beta blocker because it only selects beta 1. So we'll give you the heart effects without giving you the lung side effects. Okay. So you see bronchoconstriction under adverse effects. That's non-selective. And which beta blocker is your non-selective beta blocker? Propranolol. Okay. Non-selective can cause hypoglycemia. Why would it do that? Remember, it's
Like
giving
they're
you a
telling you
full parasympathetic
sympathetic.
response. And in
Oh, yeah.
parasympathetic,
Sympathetic,
your
your
sugar
sugar
goes
sugar,
down.
yeah.
That's right. Usually, now it's not going to usually do that to patients with regular blood sugar, but if you are diabetic, it can cause you to get low blood sugar because your blood sugars are probably already a little crazy. Okay. So in our diabetic patients and our asthma patients, you want to give them a selective beta blocker. Which beta blocker is selective?
The
Metoprolol. Okay.
The selective is the one that would
Just work on the heart, and it doesn't have any other, mainly no other side effects other than, obviously hypotension, bradycardia. Okay. All right. Highlight. Do not rapidly withdraw. Now I put a lot of red stuff on beta blockers because they're one of the most tested on drug classes because they're very common to be given out to everybody. Okay. So do not rapidly withdraw. What happens if you're giving somebody an anti-anxiety all the time, and then you stop it? Yes, everything's going to go up and very, very badly. So you have to taper off beta blockers.
Okay.
Take the heart rate before giving beta blockers. Hold beta blockers for heart rate less than. Monitor for wheezing in which beta blocker? Propranolol, because that's the non-selective. It can mask the first sign of hypoglycemia in our diabetic patients. What is the first sign of hypoglycemia? First sign. First sign of hypoglycemia. Now that's endo, so obviously it's not going to be in the same.
Are they hungry?
No. First sign. When you start going low in sugar, don't you think your body's going to kind of, it's not shaking first. You're not going to be just like, oh, hey, everything.
Something the vital signs?
Yes.
Blood pressure? No.
Y'all, they're starting to freak out because they don't have no sugar.
Tachycardia.
Tachycardia is the first sign of hypoglycemia. What's the first sign of hypoglycemia? Tachycardia. What do beta blockers do?
Calm it down.
They decrease heart rate. So you have to tell your diabetic patients, you're going to miss the first sign. Now, why is that dangerous? Because by the time they catch it, they don't know. By the time they catch it, now I'm already jittery and shaky and super hungry, and I'm just about to do seizure, coma, death.
Yes.
Okay. So you have to let them know, and I would have them, make sure that they've got liquid sugar ready to go, like the honey, the icing. Yeah. All right. Oh, look, here's our friend. Monitor for signs and symptoms of poor perfusion because it's decreasing your cardiac output. Okay. Pharmacokinetics come back to bite us. Y'all ready? Let's see if y'all can remember this. Beta blockers, non-selective beta blockers, have a first pass effect.
This means that it goes to the liver once, and then it goes to the liver again to be metabolized.
Yes, but what happens the first time it goes to the liver?
It metabolizes.
Almost to nothing. Okay, so what does that mean practically in nursing? What will I know about propranolol, knowing that it has a first pass effect?
Increase the dosage.
Which dosage? Okay, let me ask it a different way. The first pass effect is only with one route. Which route does a first pass effect happen with? PO. So that means that your IV dose of propranolol may be like 1 milligram. Yes. When you switch them to PO, it's going to be like 180 milligrams. Y'all know that because you know it has a first pass effect, so you wouldn't panic and call the dog, oh my God, you gave 180 times the dose. Yeah. Do you understand? All right. So if your patient has type 2 diabetes or asthma, we're going to give them metoprolol because it is selective. Okay. Now, if you are giving a beta blocker and a calcium channel blocker, because CCBs are the sister, right? Which means they do the same thing. You can give them both to the same patient, but you want to administer them at least 2 hours apart. Otherwise, what's going to happen? What 4 things did beta blockers do? Decrease heart rate, decrease blood pressure, contractility, electrical activity. What do calcium channel blockers do? Same thing. So you can cause, yes. So you can give them both to the same patient on the same day, but you need to separate them by at least 2 hours so you don't bottom them out. All right, do we understand beta blockers? Calcium channel blockers end in peen, but not always. And not all peens are calcium. That don't tell you nothing. Peens are also antipsychotics, okay? And there are a whole bunch of other different things. So peen doesn't tell you anything. Now, however, what I would recommend you guys doing is learning there's only like 2 or 3 peens for psych. Okay? Like clozapine is one of them. Okay, so if it ends in peen and it's an antipsychotic, then you know it's an antipsychotic. If it ends in peen and you don't recognize it, it's a calcium channel blocker, usually. Okay, so the ones you guys have to know is nifedipine, and then we have 2 random, okay? Diltiazem and verapamil. Diltiazem and verapamil. Say
and
it.
this is the generic.
Yes, these are all
Okay.
generics. Everything I
So
write will be
nif-
generics.
if-
Nifedipine,
nifedipine,
go.
dila-
Diltiazem,
di-
diltiazem,
diltiazem,
verapamil,
verapamil.
go. Nifedipine, dil, diltiazem, say it again. Diltiazem, verapamil. Say it again. Good, Ashley.
Nifedipine, diltiazem, verapamil.
Very good. All right, so calcium channel blockers. So they inhibit the calcium influx into cells. Now, when it does that, it takes your coronary arteries. If it blocks the calcium, then your arteries, coronary arteries, are just going to go and just open.
Okay.
Okay, so it is a vasodilator without being a vasodilator. Okay, and it also decreases the action potential because remember, calcium and potassium have to switch in order to make electricity.
Yeah.
So if it decreases the action potential, that's how it decreases the heart rate because there's no bzz to make it go boop, boop, boop. You see what I'm saying? So it does the same four things. Y'all with me?
Yes.
Okay, but listen very closely to what I'm about to say. Beta blockers work better on heart rate. Calcium channel blockers work better on blood pressure. That's why I put them in a different order. Okay? So like if you have a patient, let's say their heart rate is 147. They're chilling, nothing's wrong with them. Okay? I would probably put them on a beta blocker. You got a patient whose blood pressure is 220 over 110, I'm going to put them on a CCB. Okay? Y'all see what I mean?
Yeah.
Okay. All right. So what do calcium channel blockers treat? They treat, you'll see the same things basically: angina, hypertension, dysrhythmias, migraine. Okay. They will also cause hypotension because it decreases blood pressure. So they may feel dizzy or may have a headache. Bradycardia, we already saw coming, right?
Yeah.
All right. Verapamil. I don't know why they love this fun fact, but NCLEX, ATI, everybody loves this fun fact. Verapamil causes constipation. Who gives a shit? Literally. Okay. Like, I don't, okay. So what? Like, you know what I mean? Okay, fine. So if they're going on verapamil, maybe increase their FFM. What's FFM? Fluids, fiber, mobility. Fine, fine, but not too many fluids because it causes edema. Okay, so I want you to see edema is also a big side effect, but that's a given.
What was the other one?
Fluids, fiber, mobility. It does have an antidote, just verapamil, only verapamil. Guess what the antidote is? Calcium gluconate. Dude, I bought some of that from a online store because I'm like, damn, it's an antidote for literally everything. Like literally everything. You get too high potassium, you got calcium gluconate. Calcium gluconate can also help with radiation poisoning as well as potassium iodide. So I'm like, shoot, if the world goes down, like I got calcium gluconate. We gonna be just fine, you know what I mean? Okay. So give calcium gluconate if they go toxic. Now, nifedipine. This next fun fact is one of the most testable things you'll see. Nifedipine causes gingival hyperplasia. Now, it's very important for you to note. You will see gingival hyperplasia as a side effect of a bunch of pharm drugs. Do you know what that means?
Is this with your mouth?
Yeah, your gums get red.
Your gums? Okay.
Am I going to call a doctor at 4 o'clock? Doctor, come quickly. The patient's gums are red.
No.
No. So it is very commonly tested on as a side effect, but it is not reportable. Okay. Okay.
Yes.
Okay. So nifedipine causes gingival hyperplasia. We can also use it if the patient has heart block. That's the best one to use. Okay, because you know calcium channel blockers can cause heart block.
Yeah.
But if the patient already has heart block, but I need it to decrease their blood pressure, that's the best one to use.
Okay.
Now, nifedipine can also cause reflex tachycardia. What is reflex tachycardia?
Come and go.
What is a reflex?
Fast.
Yeah, like it automatically just happens, right? Like if I scared you, you have a startle reflex, right?
Yeah.
So reflex tachycardia, what happens when your blood pressure goes and tanks? How does your body compensate?
Tachycardia.
Increase heart rate.
Yeah.
We know that hypertension, tachycardia always go together. So this is a reflex tachycardia, which means you give a patient a beta blocker, they take it, their blood pressure goes down, so their heart rate goes up. That's a given. Does that make sense? Okay. All righty then. Bam. Okay, adverse effects. No big deal, just cardiogenic shock. What is cardiogenic shock?
Your heart stops.
You're going into shock, which means what?
Your
No perfusion to your
heart.
ma'am.
No, to your kidneys.
To your kidneys, and then the word in front of it is how we got there. So calcium channel blockers can relax your heart so much where it's not pumping very well. And if there's not a lot of blood coming out the heart, your kidneys won't get a lot of perfusion. Okay. Edema is one of the number one side effects, or I guess you could call it side effect or adverse effect of calcium channel blockers. You do have to report that because if they get sudden worsening of edema, they're either the calcium channel blockers are too high of a dose, or we use these in heart failure sometimes, right? So what if the patient's getting worsening edema and they have heart failure? You know you have to report that, right? Because it can mean their heart failure is getting worse. Now, calcium channel blockers are not liver toxic, but they can cause elevated LFTs, so it's just something we have to watch for. And then heart block we already saw. So you'll see that very similar nursing care to the beta blockers because they're sisters, right?
Yeah.
So you're going to take the heart rate and blood pressure before you give, watch their EKG. Now highlight, report new onset or worsening edema. Because what does that mean?
Fluid.
They've got extra fluid. Something is either the calcium channel blocker dose is too high or their heart failure is worsening. With verapamil, we need to increase FFM. I also put V in there, which is veggies. Because verapamil can cause constipation. Verapamil can cause constipation. Okay. Caution taking calcium channel blockers with digoxin. Why would you be careful giving calcium channel blockers with digoxin?
For toxicity.
But you have to
For
give
the
me your.
digoxin toxicity.
But how would calcium channel blockers cause that? They don't cause hypokalemia.
No, but they're on the seesaw with potassium.
But this doesn't cause anything with potassium. She said,
It
oh.
won't lower the blood pressure?
Digoxin does nothing with blood pressure.
Yeah.
It's what?
Oh, it's the heart rate.
Oh, okay.
Oh, 'cause
Heart rate and
digoxin-
contractility.
sorry, yeah.
So digoxin and calcium channel blockers kind of now
Yeah,
digoxin
lowers-
increases
the heart
contractility
rate.
and this decreases. So
Decreases.
those would opposite each other,
Yeah.
right? But digoxin lowers heart rate and so do calcium channel blockers. So you just got to be careful because some of it will cancel out and some of it won't. Now, why would you be careful giving calcium channel blockers with beta blockers?
Because they do the same thing.
They do the same thing. So remember, if you're giving them together,
You're like upping the dose.
what happens if you're going to give them together?
Oh, then the heart rate and everything's going to go down.
Let me ask you in a different way. What is the nursing consideration if a patient has beta blockers and calcium channel blockers both ordered on their MAR?
You're going to give them 2 hours apart.
2 hours apart, so that way we don't bottom them out. You with? All right, do we understand our first sisters, beta blockers and calcium channel blockers? Okay, sisters, do the same thing.